Floor is yours.
Thank you so much. I'm really grateful for having this opportunity, and I'm very happy to see my friends here because I come in this marvel city since more than 14 years, and I know the doctors, the professionals, and the people of Qatar. And Hospital is a fantastic place that was developed to do excellency and high quality treatment, and it's an honor to be sharing with you work and cases and teachings, and this is why I'm always happy to give when I come the lecture, the invited lectures. No, but actually they are the same old topics I was discussing with Conchi and about how we define humans and how we can predict some happenings like traumatic events or sports events or degenerative events in the lifetime of a person. And this is our also our possibility as scientists, because we do surgery, we do medicine, we do rehab, we take care of the humans, but can we predict how many we will have next week, how many cases and what different cases will arrive next year, how the society is moving, how the quality of life interferes with the length and on the lifespan. So it is very interesting to discuss. So this topic today is the AC joint. So what can you say new about the AC joint? Actually, there are very few new things that we can share, and I don't like to share like new techniques because each year there are so many new techniques, and each year so many new techniques just disappear because all new techniques that are not having more than 2 years of follow-up and results evaluation are not meant to be used perpetually. And if you work in private practice, doing a procedure that has less than 60-70% good results is a risk that you cannot take. It's not experimental. So we will speak about what we know and what is actually acknowledged about the AC joint. And as you know, the AC joint is a joint. It's the arthrosynovial joint made in the upper part of the shoulder. It's very visible. It's a place that we can touch very easily, and it's very exposed to trauma and to degenerative diseases. And this joint is normally asymptomatic, so it allows us to move and to hold and to use the arm in different conditions and with different strength and different motions, and it will be interfered by the aging and also by trauma. So as you see, we always go to anatomy. So these are the surface of the acromion that is proposed and opened for the clavicle is very nicely oriented. It's have an oblong shape and is covered with cartilage. And this joint is completed by the clavicle that have also very nice cartilage that have a convex shape. So the convex shape of the clavicle comes perfectly joining the concave shape of the acromial area, and that makes the coracoacromial joint that is empowered by a capsule, and where there is a meniscus inside. So this joint is actually quite mobile and stressed by weightlifting or pushing. There are some ligaments also keeping the AC joint stable, because the power of the arm is impressive, and people who deal with the sports or deal with patients they operate on or they follow as a physical therapist or sports medicine doctors or rehab, they will know that an arm have about 7 to 8 kilograms. So 7 to 8 kilograms. So if you fix the arm and you hold the pressure in the joints that are keeping the arm standing in this position, being stable, you have to be able to hold 7 to 8 kilograms. So it's the same if you hold a sling. If you put the arm in a sling, the sling will hold 7 to 8 kilograms. But actually it's not 7 to 8 kilograms, it can go up to 40 kilograms because the arm is moving. The arm is also holding. The arm is also used as a weapon or as a lancer. And so when you fix or you check those joints in the shoulder or the upper part of the body, including the scapulothoracic joint, you have to hold 40 kilograms, not 8. So the ligaments are strong. They are known from anatomy. We learned that in the first year of medical studies. There are those two ligaments, the trapezoidum and the conoidum. So that's coming from trapezius and cornus. These are Latin terms to define a trapezoidal shape or a conical shape. So those two ligaments are very strong, and actually they keep the clavicle at the equidistant length as compared to the scapula. So when you look into the shapes of the clavicle as compared to the acromion, the angles of the AC joint can be variable. They depend also of the angles of the sternoclavicular joint, because the clavicle is held on the medial side by the sternum. That is a joint covered with a fibrous cartilage and hyaline cartilage, and on the acromion. So when you see the clavicle and how it moves, actually the clavicle moves very little, and it's actually making some rotation in the axis. So otherwise it will not go up, it will not go down. It will not go in the back, and it will not go in the front unless there is some trauma. So pathologies of this AC joint can be non-traumatic and traumatic. Everybody knows about trauma of the AC joint because everybody had patients with falls and painful shoulders, and when you look into it, they can be AC joint. Non-traumatic lesions of the AC joint are often misdiagnosed. They become very popular now because of the weightlifting and bodybuilding. So many people, including here, are occasionally weightlifters, occasionally bodybuilders. So real sports people, real competitive athletes have less accidents than occasional athletes. And they develop less arthritis until so maybe more after they stop sports. However, the regular population have more arthritis, including the AC joint. So distal clavicle arthritis happens in people like that. So they have strong muscle, they have good bones, they can lift 30 kilograms with one hand, they are able to push, and then they can develop this kind of lysis of the clavicle. As you see, the joint is open, so the joint is not normal. It's quite bigger than the other side, and there is a part that will vanish, and the quality of the bone and the the density of the distal clavicle will change. So the angle of this joint will change as compared to the normal, because you always compare the normal to the other side. Usually it occurs on one side, the AC joint arthritis. And as you see, this is one side and this is the other side. It's not the same, situation. So other types of AC joint arthritis, also related to sports, they develop cysts, they develop stiffness of this joint, because if the joint becomes stiff, they have pain when they lift. And you see those little bone cysts are extremely painful because they are surrounded by inflammation. And I do this procedure of removing the distal clavicle on a regular basis. I do it usually open. I don't like to do it with a scope, because with open the open Mumford procedure, the recurrence rate or painful post-operative situation is close to zero, and with arthroscopy the recurrent pain is about 50%. So 50% of the AC joint post-operatively it's not interesting for someone who's performing this on a regular basis. So this is the anatomy. So we open, as you see, the joint is opened. We did the longitudinal incision separates the deltoid from the trapezius. That's what we call the deltotrapezial raphe. So that's it's an area where the fibers of the trapezius blend with the deltoid over the clavicle. So when you open this, you have to open in the line of the AC joint. So it have to be in the line of the capsule. And then the capsule is open and you will see the cartilage. So when you see the cartilage, the cartilage is torn. So what we do, we denervate this distal clavicle. So we burn literally that last centimeter of the clavicle to make sure there is no more pain messenger from this area. And then we make a resection, a bone resection of this part. And we obtain a surface that is not in contact anymore. So there is no more contact between the clavicle and the acromion when the people who use their arm. So that means no more contact, no more pain, because the pain comes from the contact of the clavicle with the acromion. So after the resection, it looks like that. So as you see, the clavicle position is still good because we don't touch the ligaments. There are, however, cases, some percentages of resection that is too high, too big, and in some cases the ligaments are touched, and it will result in a unstable clavicle. I had also 2 cases. So this is the part of the clavicle that is resected. And as you see, this area is filled with inflammatory tissue. After surgery, this test, that is the most prevalent test for AC joint arthritis, is called the X crossbody, is negative. So before they are unable to do that, so they do and after the surgery they do normal crossbodies, and the crossbody is symmetrical. How we measure the crossbody? You measure the distance between the elbow and the shoulder. So you bring the elbow as close as possible to the shoulder, and you measure this distance. So you stay behind the patient, so you measure with the centimeter this distance, and compare to the other side, because it's symmetrical. So it should be symmetrical. So this is the patient, and we had... I published a series of distal clavicle arthritis in young people. They were hurting for more than 1 year, 1 year and a half. They had impaired shoulder function with impaired SST, and they were treated, and the results were good because they returned to work and to sports, and they were mostly asymptomatic. So that's a chapter that is interesting. It is well to know about it. You will see cases. You will see cases in people who do sports because they develop arthritis regardless the trauma. So every sports patient will experience some trauma, but some of them they will make arthritis. So then if the arthritis is symptomatic, it should be treated. So it can be treated also with a scope. My experience is better. I did it with a scope, but it's better with it's a mini open procedure. So the traumatic AC joint is something else. As you know from studies, the AC joint stability is related to the presence of ligaments. So the ligaments are strong. They are really strong. They can hold many kilograms. You are unable as a person to break that kind of ligament. So there are ligaments in your body that you can rip or pull, but those acromioclavicular ligaments are very strong. So as you know, they oppose to the movements of the clavicle as compared to the acromion, and the stability is depending on the loading and of the integrity of the ligaments. So if the ligaments are torn, there will be instability. If the capsule is torn, there will be more instability. So these features, these anatomic components have to stay well. And as you see in anatomic dissections, if you cut the capsule, the joint will open. So it will open, and that's not a normal thing. So it opens more than 5 millimeters. That can be pathologic. So these are the superior ligament that you can see, and the inferior ligaments are also described as the trapezoid and conoid. So all those ligaments are extremely strong and fibrous. As you see here, if we cut the capsule on a specimen and we pull, we make all possible manipulation as a man making the experience, the experiment, and he's strong, and we ask from him to pull as much as possible. So he will pull, and whatever he is doing is unable to break those ligaments. So you see that if the clavicle capsule, the capsule between the acromion and clavicula is broken or open, the AC joint will not move because of the ligaments. And if the clavicle is fixed on the sternal side, it will stay stable. So what's going on? The injuries of those areas are quite frequent. You will see every day in practice. Usually there are young people. They account 12% of the injuries of the shoulder girdle. That shoulder girdle accounts about 5% of the injuries of the human body. So you will say it's not a big deal, but actually not big deal. As you report to 8 billion people, it's a real big deal, So there are many, many cases everywhere, especially in sports clinics. The mechanism of injury is very typical, and usually there are falls from two wheels or falls during playing rugby, playing football, soccer. People who are doing climbing and they had a fall on the limb that they have one limb blocked, and they had a fall on the other one. So different types of trauma and different types of anatomic features. So when the AC joint is injured, the first it can be displaced and it will show a different anatomy depending on the strength of the trauma. So this is the first one. So there is a blunt trauma exerted on the lateral side of the shoulder. The ligaments will move a little bit, the clavicle will move a little bit, but there will be no anatomic harm. The second one is that you have this trauma, the capsule is broken, but the ligaments are still there, so the displacement exists, but it is not significant. So that means that that kind of injury can be treated conservatively unless it is very painful or it will develop osteolysis of the distal clavicle. But otherwise, 6 weeks later, you will see a good shoulder. So this is third degree that we see very often. So the acromioclavicular, the coracoacromial arch is intact. The capsule is torn, and the trapezoidal and conoidal ligament are torn. This is what we see very often, especially in sports. So it's a trauma that is very often seen and very often treated by conservative methods, and very often have with an excellent success rate without surgery, because the position of the clavicle is not changed in the economy of the body, so it will go up a little bit, it will be riding high, and that's it. It will not go in the back, it will not go in the front, it will not go down, it will just go up a few millimeters, and this is what it is. So another more severe trauma is then when all those ligaments are torn, the clavicle comes back, and this is extremely painful. Why? Because the meniscus inside the joint is torn, and when the distal clavicle comes back, it will pinch that area and the meniscus, and each mobilization will be bad. So when you do x-rays, you see a quite normal shoulder, but the patient being symptomatic, you should bring him back to clinic 3 weeks later to make sure, and then you will see some osteolysis and the beginning of a sufferance of the AC joint. So another type of trauma is this one. This one is quite severe, is the type 5, where the clavicle will be displaced, the capsule is torn, the ligaments are broken, and the posterior part of the distal clavicle will go in the trapezius. As you know, if you pinch your trapezius, it's very painful. It's one maneuver made by the anesthesiologist to wake up patients in the operating room. So you pinch the trapezius. It's very, very painful. So when the clavicle goes in the trapezius, it will be really, the patient will be really unhappy. So he will come in emergency. He's very painful, so he's symptomatic, unhappy. Pain medication will not be enough, so those patients should be operated quite fast. So this is another feature that can show. So everything is torn, it's broken, and the clavicle will go very much high. So that is not high like 1 centimeter or 2. It can be 4. So it's really a bump that the patient cannot take. He don't like it. The shoulder becomes asymmetric, and the aesthetic of the joint is changed. So the patient will ask for surgery and for help. That's another case that is really, I haven't seen one at all. So that's described in the literature. Is the type 6 by Mr. Rockwood. So Mr. Rockwood maybe he saw one, but nobody. So if you say, have you seen type 6? No. So everybody knows about type 6. They can also, because like it's always paradoxical, like say the medical students, there's a type 6. Type 6, they can draw, it's very nice. But have you seen one? No. So that's something that I haven't seen. So the clavicle is torn with the ligaments, and it becomes unstable, and by some mystical, very special mechanism, it goes under the coracoid. I don't know how, because it's very difficult to get the clavicle under the coracoid, and it's there. So when you see that, you have immediately to take it out, because the musculocutaneous nerve is there, the arteries of the arm are there. So if you see that in some accident, remember this talk, and that so you make a picture and send it to the journal, because it will be published. So I saw type 6 of AC joint dislocation. So the overall 90% of the AC joint traumatic disease are benign, and they don't need surgery. They are well followed. The patients return to sports. When you see the rugby team of Toulon, they have all bumps of the AC joint. You see the same in New Zealanders, Australians, South Hemisphere, North Hemisphere, Ireland. Everybody playing rugby, they have AC joint, and some of them they have like the bodies like that. So it's a shape. It's not muscles. It's just AC joint dislocated when they were like 16, 17, and they stay like that. They are completely normal. So unusual dislocations happen in people who have a very strong periosteum. So as you know, in very young people, like 15, 16, they do sports. They are very competitive, and but the bone is weaker than the ligaments. The ligaments and the periosteum are very strong. So that kind of thing happens. So you see, the bone is avulsed, and all the sleeve of the ligaments and everything stay down. So the clavicle is out, but the sleeve is there. So this is you should perform some MRI or some ultrasound, very good exam to make this to see that, because on the X-rays you will think the ligaments are torn, but the ligaments are not torn. They are there. They are with the periosteum. So by putting the clavicle back in place and fixing for temporary, it will heal very well, and that's especially in adolescents. Okay, so unusual type of dislocation also occur with fractures associated with the coracoid, or separations of the joint where the ligaments are intact with some very strong trauma, like a vehicle trauma. And what you see very often is that, so you see a patient coming, he have a sling, and some recommendation from his doctor that he should wear the sling, because the sling will put the clavicle back. So sometimes they put a strap on it, or they can put elastic or a scotch, to push it down. And actually, it's completely useless, because it's not the skin that will put the clavicle back to bone. It's the whole weight of the arm that goes down with the rupture of the center. So when we fix, we have to be careful by doing the operative reduction, and to fix the ligaments, either with using a graft, or by making some artificial harvesting, or by transposing a ligament that is already in situ, like the coracoacromial ligament, that can be used as a graft. So should we do that immediately? No. Usually with the sports doctors, we agree that we follow the patient for 6 weeks after trauma of the AC joint. And if in 6 weeks he's still symptomatic and painful, we proceed to surgery. Otherwise, in 6 weeks, usually 90% of the patients with trauma of the AC joint become asymptomatic, so no need for surgery. All those reconstruction are associated with excision of the distal clavicle, because the distal clavicle, that last centimeter, is extremely painful and exposed to degeneration and osteolysis. So we will fix it, we'll put it back. The radiology is very nice, but they are still painful. So if you go in to fix it, we fix it, and we make a resection of the last centimeter of the clavicle to make sure that those body surfaces are not in contact anymore, so no more source of pain. So the reduction is important. The repair should be made in a good physical manner. The open procedure is preferred by some surgeons. Arthroscopic procedure is preferred by some surgeons. However, very few have a long follow-up. The vast majority of the surgeons who are performing new techniques have a follow-up less than 6 months. So that is a problem, because when you deal with a team or you see patients in a long longitudinal series, some procedures are not very well supported, or you have patients, like about 40%, what happens with patients after surgery, 40% they will not return to sport at the level they had before. So this is interesting. So there are some types of stabilization. One is largely proposed in some trauma centers, especially in China, where they developed this plate. It's a special plate that is giving very nice radiology, but it's a catastrophe in terms of result as a long term, because if you fix it like that, you have to remove it, and it's a quite aggressive procedure. The stabilization of the acromioclavicular ligament can be made by different type of screws, cannulated screws, by Bosworth screw that is proposed 60, 70 years ago, and it still works, by suture anchors, by cerclage using different materials, PDS, Mercyland tape, strong wires, tight rope. Nice, a new minimally invasive fixation of the acromioclavicular joint, or using artificial ligament like Lars. So this is a case of type rope that is quite interesting. So if you do it well, the patient is happy, they have very good results. Fixation can be done, so the drawings are describing the technique, but actually it's not exactly like that. However, it should be providing some primary stability. I mean, is it the primary stability important? Yes. Is it determinant in the outcome of the joint? Is not sure, because many of those repairs will deteriorate later with some osteolysis 6 months later, 1 year later, or more. So the chronic instability is seen very often. Actually, we see more chronic instabilities than acute AC joints. They should be fixed if they are symptomatic. Once again, we speak about 10% of the 12% of the 5%. So there are really not so many. So 10% of the AC joint trauma. If they are chronic, and I see about more than 100 AC joint traumas and cases per year, and we operate about less than 20. So that's it's our experience with our cases. So that procedure was described by Weber and Dunn. So The procedure consists in taking the ligament of from the acromion, so it's the coracoacromial ligament, and fixing this ligament on the clavicle. So if you fix this ligament on the clavicle, that's a graft. So there is no more trapezoid, no more conoid ligament. So you replace everything with this new graft, and this can be done with a scope. It can give very nice results. The clavicle is stable. It should be associated with some resection of the distal clavicle to make sure that it is not painful. With the open procedure described by MacDonald, who's a very famous surgeon, looks like a quite heavy and large procedure. I did many of those, the reconstructions using the Waver-Dunn procedure by using the anatomical coracoacromial ligament. The reconstruction is made by putting the graft and pulling the tissue under the coracoid, because there you have the best possible stability, and putting back the clavicle to its anatomical position. As you see, this is a case, and it's quite prominent. It's a patient that was over 3 months after a trauma, unhappy, symptomatic. So we take as you see, there is no more ligament under the clavicle. Everything is torn. There is kind of fibrous tissue over there. You cannot reconstruct ligaments over there. So the case is fixed with a suture anchor and a screw that is removed 10 weeks after the surgery by under local anesthesia. So it's quite good procedure. Why? Because the patient is happy, no more pain and pressure on the skin, and he can go back to normal activities. This is the harvested coracoacromial ligament that is used as a graft. So we augment the strength of the repair and use this ligament, and it will result in a very nice plain area where the clavicle is down and its anatomical condition, and the patient is completely pain-free after the surgery the same evening or the next day. So it will be like that. The reconstruction with the Waver-Dunn procedure, it should be protected by a sling for 6 weeks, especially sling for every moment when the patient will go out. If they go out in town, they should wear the sling, because there are more trauma by very usual activities like going out, getting into a door, pushing for some place in a public place, like opening a window or something, and they have more trauma with that than with sports after surgery. Some complications, of course, they can occur with wound infection, failure of the implant, local disturbances like prominent clavicle, again, some inflammation. Also very unhappy, and for us good, not so frequent events like a fistula after playing with the arteries near the axilla, or injury of the brachial plexus by traction or by local block. There are also discussions about should we do it open or should we do it mini-invasive, or should we do it with a scope. Actually, all those, as I was telling you, when there are over 180 procedures described, and the half of the procedures described have less than 2 years follow-up, you cannot make a correct assessment and recommendation on a scientific basis. So we do what we know, and we do what we have as a result and as a evidence with more than 5 years follow-up. So there are different series, and you should also remember that the patients are not the same. So different morphologies, different types, different sports, different ages. So this is not the same area. Arthroscopic procedure is now an option. It can be done very nicely. The durability of the reconstruction is not very clear. The patient have, some of them, they have longer follow-up, but the vast majority have less than 2 years. Some cases result in severe chronic AC joint dislocation. So this is a patient I fixed with the waiver done more than 7 years ago. So the patient is very happy. He returned to normal activities. He's doing weightlifting and doing well. So what about complications? Complications when treating the AC joint can be occurring with operative treatment and non-operative treatment. As you see, infection 1% with non-operative, 6% with surgery. Deformity with non-operative 37% and 3% after the surgery. Normal ranges of motion, careful, 95% normal after conservative treatment, 86% normal after surgery. That means 14% of the patients are not happy with the ranges of motion after surgery. That means that those 14%, if they are sports and competitive players, they will not go back to sports in the way they were doing before. So it's a part of what we know. The normal strength is stronger, get better with conservative treatment, and the pain with non-operative treatment is better. So there is less pain with non-operative treatment than with operative. So these are complications with open and arthroscopic procedures. So as you see, there are complications. So this is not an easy surgery. Why? Because the area is small, and the forces that pull and push the AC joint are very strong, especially in sports people. As you see, reconstruction, these are cases. This patient of mine, I fixed him with a reverse total shoulder. He had the AC joint repair 10 years before. So he was almost 60. It resulted in this severe arthritis, so we made it a arthroplasty with a good result. That's displaced clavicle type 5 with a riding high and back clavicle that is in the trapezius. Without surgery, we see instability, shortening of the clavicle, and pain. So that's without surgery. This is with surgery. After surgery, you can have instability, shortening, painful shoulder, plus infection, and plus neurological condition. So as a surgeon and as a specialist, if you decide to treat surgically, you should be very careful and to really be comfortable and used with the technique you make. And I personally am very comfortable and happy with the AC joint, but also very careful in making the indication for surgery. So conservative treatment is sometimes very well tolerated. Material, if you put material, can migrate. As you see, it can do arthritis. That ligament that you fix will be ossified. It will result in that kind of deformity after arthroscopy. It will result in anesthetic anatomy and in unstable clavicle. So as you see, arthritis is quite frequent. This is a case that we did. So we did a fixation of the clavicle, and it was not good, so we did a tightrope, and the tightrope resulted in dislocation, the secondary dislocation, so we fixed finally with a distal clavicle resection. As you see, after the second fixation, it displaced again, so we have to make it open with a graft, and it was a good result. So failed reconstruction are seen also with a clavicle that is not in the anatomic position. Patients with this Chinese material have lots of osteolysis and painful shoulder. However, they have a good function. But this material is not good because it should be reopened, and risks after 2 surgeries, quite important surgeries, are high. So type 4 AC joint dislocation was fixed by surgery. We were done. Very good result. However, as you see, the lever arm of the clavicle is shortened. The patient is happy, asymptomatic, having full strength, but his anatomy was distorted forever. So this can be seen also if you are interested in seeing the patient with a comparative 3D CT scan. So you perform the CT scan, ask for reconstruction from the radiologist, and you will see very nice images with the clavicle and how is it positioned, and if the clavicle is torn, rotated or not. Another feature that you can see, especially in old people, post-traumatic or arthritic AC joint cyst that is related to the fluid that is inside the joint with the clavicle. So osteolysis is also seen. As you see, this is a case with osteolysis. It's quite typical. And after the surgery, if we remove too much bone, it will result in a gap that is quite aesthetic, not only on the radiology but also in normal life. So these are the conclusions of the study. There are more complications if the AC joint is treated with surgery, in long series, in big cases. So many complications, about 10%. So 10% is more than nothing. And without surgery, we have still complications, but less dramatic complications. So this was the topic of the AC joint. I hope that I offered some anatomical principles and not discourage you for treating the patients, because as you see, this is an area that is quite sensitive and sensible also, because usually it happens with the dominant arm, and if you don't manage well, the patient will be frustrated and coming for many months to see you in clinic. Thank you so much.